Hello, welcome everybody. Uh, Today we are going to talk about infertility workup. Before I start the subject, there are a few things I would like to say. Infertility is a specialty, or shall I say, subspecialty of obstetrics and gynecology. When I was at your stage, this specialty wasn't there. It, it was part of general gynecology. And because infertility doesn't cause any severe pain, discomfort, or acute symptoms, so infertility was never taken by gynecologists seriously. It was always put on the back burner. That, all right, oh, and there wasn't much to be done as well. No technical facility which is available these days wasn't available then. So both ways, neither the treatment was so much advanced nor the doctor had patients for cold cases. They were too busy with the acute obstetrics and acute gynecology. But now gynecology is developing subspecialties. Amongst them is infertility. I will very strongly recommend to the lady students who do not wish to get into acute medicine where there are a lot of emergencies. They have to take calls at night, wake up, go to the hospital. They would like to work 9 to 5 kind of thing, and no emergency calls. And particularly lay doctors who are married, they would want this kind of specialty where they go out for 9 to 5 and then be available to their children and husband at home. So that's why I would very strongly recommend that those who wish to do this 9 to 5 kind of job, they should seriously consider subspecialty of gynecology, infertility, to practice when they become the specialists. Today, the subject is infertility workup. Let me see where here. Well, eh, the topic, as you see, is really changed to subfertility. There is a reason for that. That previously, long time back, infertility was, patients were labeled as sterility, absolute terminology. But then when treatment was available, the terminology was changed into infertility. Now, because most of the patients who are infertile, they can be helped. So the terminology has been changed to subfertility. Subfertility, its definition is inability to conceive following 1 year of unprotected intercourse, people getting married and living together and not using contraception or family planning methods, and they do not conceive, or the wife does not become pregnant for a year, then that couple would be labeled as subfertile, and provided they are young, and that means before age of 35. But those who are over the age of 35, these days it's quite common for girls to delay their marriage because they have adopted a profession and they're professional girls. So they don't want to sort of get behind the boys. So they delay their marriage till they are well established. So if the girl is beyond 35, then we take it seriously after 6 months of marriage. And as I said, safe fertility is rarely absolute. Very few patients are who cannot be helped, but most of them can be helped. That's why it is subfertility is more appropriate. The incidence of subfertility is very high, I would say, very high, because nearly 1/6 of the population, uh, it- if today 100 couples get married, out of those, 16 will not conceive during their first year when they're trying for baby. So 16% is quite common, whereas possibly in developing world, if the incidence is even higher, it may be even 20%. So you can imagine, out of 100 couples who get married today, 20 will seek your help when they fail to become pregnant. If we look at the possibilities of pregnancy, if a couple lives together and there are no subfertility cause, both are normal, then every month there is nearly 15% chance of the wife becoming pregnant if they have unprotected intercourse. And but unfortunately, this possibility of 15% every month declines with age. After 32, the incidence drops, and after the age of 37, it becomes a serious problem because with natural changes in the body, the chances of fertility are very low after 37. That's why in England, those who seek help after 37, they are refused because they feel the chances of success are very low. So national health patients are not provided help after 37 years of age. And this is proved because after 35, if a patient becomes pregnant, then there's a very high risk of miscarriage or abortion. And this generally is because of anomaly of the genes or chromosomes, and which genetic changes take place. And that's why the fertility rate is low after that. Now, generally in our society, unfortunately, if there's subfertility, then the wife is blamed all the time. Problem with her, particularly in-laws pressurize her that the cause is with the wife. Whereas if you look at these figures, both are equally responsible. There are 40% cases, there's female factor, and same number, 40% cases, male factor, and 10% where both are possibly responsible for subfertility. So remember this, that if you're going to investigate or do a workup for infertile couple, you have to investigate both. Even when husband says he's fine, he doesn't need investigation. Maybe he's okay having sexual coitus, but having easy, good coitus doesn't necessarily mean that his semen analysis is normal or he doesn't suffer from oligospermia or azoospermia. And if we look at the female, most of the causes in the female belong to the tubal factor, fallopian tubes. And same number is ovulation failure. So if a couple comes to you with the complaint of subfertility, in the wife, you will think of these two first. First, ovulatory cause, whether she's ovulating or not, and second, whether her tubes are healthy or not. If both are okay, then very small number, the cause may be in the uterine cavity or cervical mucus. But that is uncommon. Most of them are either ovulation failure or tubal blockage. Similarly, in the male, the cause, spermatogenesis takes place in the testes. And this spermatogenesis is stimulated by pituitary hormones. If for some reason the pituitary hormones are not produced, or there is genetic defect that pituitary is not producing its hormones, gonadotropins, then obviously testes will not be stimulated, so there will be no spermatogenesis. Here, testes may be normal, but hormones are abnormal, FSH and LH. But then the second cause could be in the testis. That's the most common cause. The failure is in the testes. They are not. There is no spermatogenesis in the tubules. The sperms are the various stages of sperms are not present, and sometimes it happens that testes are producing oocyte, but there's a blockage in the system which conveys the spermatozoa from the testes to the ejaculatory ducts and during coitus in the ejaculate. So the causes in the male could be before the testis hormones, in the testis, or post testis. That means a blockage, or that is called a blocked tubes or sperm vas deferences can be caused, and very rarely the husband cannot perform coitus properly, so the semen is not planted in the vagina, and that leads to subfertility. With this knowledge of theory in the background, now if a couple comes to us uh, with the complaint that they have failed to conceive or become pregnant, then obviously like any other medical problem, they will take first detailed history of husband and wife, both. Remember both, and then do physical examination of both husband and wife. And then, according to the history and physical examination, certain investigations will be carried out. History of the female. Well, age is very important. As I said earlier, after the age of 32, decline starts, and after the age of 37, the decline is acute. So, age of the patient is very, very important. So many times in my clinic, I see patient over a 40 when there's very little we can do medically for them. And then obviously her occupation, if she's too busy in the job, she is not available at home, that could be possible for infrequent coitus and infertility. Then breast development. If her breast development is normal, we presume her hormones are okay. And similarly, excessive growth of hair on the body, which is called hirsutism, if it is present, it is one of the symptoms of or signs of uh, polycystic ovaries, and in them infrequent ovulation takes place. Similarly, excessive growth of hair, excessive weight, that if the woman is over, her BMI is over 25, then ovulation chances are less. If she suffers from any other medical illness, hypertension, diabetes, thyroid diseases, again, their ovulation is infrequent. If she takes any drugs, particularly she had treatment for malignancy, she had medical treatment which affects the testes as well. So we have to take detailed history about that disease or problem. And if she is addicted to any recreation drugs, that they are also responsible for. So detailed history is very important. Generally speaking, in a busy clinic, we don't have time for such details. But if we do, maybe just from the history, we'll find the cause of infertility. Then, obviously, menstrual history is very important, whether menstrues are regular or irregular. And the patient's concept about menstruation is if they are menstruating regularly, they feel that ovulation is taking place. It's not directly related like that. So, regularity of menses or any other problem may be of help. Of course, history of amenorrhea means possibly ovarian failure or the lack of production of ova from the ovaries. Similarly, if she is not suffering from primary subfertility, it is secondary, then past obstetrical history may be very important because if she is delivered at home, postpartum infection or hemorrhage are leading causes of subfertility in those cases where they suffer from secondary infertility. Similarly, if she has used any contraception, particularly IUCD, intrauterine contraceptive device, uh, there's a risk of infection, and if infection takes place, tubes get blocked. So it's important to take history. Whether patient may say, I've been married 2 years and no child, whereas out of those 2 years, if she had taken contraception for a year and a half, it means only they have been trying for 6 months. So that's why contraceptive history is very important. Similarly, sexual history, where the coitus is taking place regularly, and normally young couples, they have coitus 2 to 3 times a week. That's normal. If they are having coitus 2 to 3 times a week, then timing of the coitus becomes unimportant. Generally, people have concept that 12th or 14th day are very important for coitus. Yes, they are important if the frequency of coitus is only once a month or twice a month. But if they're having, like young couples, other young couples, coitus 2 to 3 times a week, then timing is unimportant. But satisfactory coitus is important. If husband suffers from pre coitus ejaculation and premature ejaculation, and a wife is having dyspareunia or painful coitus, maybe that is, or even uh, apeunia, no coitus. So all these, of course, medical and surgical history related to the fertility are also important. After you finish with the female, all the detailed history, similarly, history of male. Any problem regarding coitus or his occupation. If he is working in an area where the high temperature or toxic fumes, like traffic warden standing on the crossing, all the fumes he is inhaling, they can cause oligospermia. And if the husband had previously semen test done, what was the report? Then it's a great help to learn about that. And similarly, if he suffers from any diabetes, hypertension, takes drugs, so all those, again, detailed history, and of course, sexual history, as I said earlier, normal practice is 2 to 3 times a week. Ask whether he suffered from ejaculatory difficulty or sexual dysfunction. Then past history. Husband may be married twice, having children from the first wife, or married twice or thrice in Pakistan society, no children, and without having his own semen tested. So past of history of any marriages, any children, or even his own personal history of mumps or tuberculosis, which can affect directly testes. So all these histories are important. And then family history is also important. So many times the husband gives history that there are two, three brothers, none has children. It means perhaps some genetic problem. So detailed history of the husband is also important. Then we come to physical examination. Physical examination is general physical examination and local examination. As I mentioned earlier, BMI is important. Overweight, if the BMI is more than 25, ask them to reduce weight. That could be a significant factor in disturbing the hormone system. And if the female, look at the secondary sexual characters, whether they are well developed, like breast, like pubic hair, whether they are developed or not. If they are not developed, possibly the hormonal cause or pituitary factor is responsible for subfertility. And then PCO in Pakistan is very common. Nearly 40% girls, they suffer from PCO. And if there are signs and symptoms of PCO like oligomenorrhea, irregular menses, hirsutism, and acne, they are all part of PCO. So look for those. And similarly, Thyroid function, if it gets disturbed, then it leads to subfertility. Examine thyroid and if need be, do thyroid tests. Breast examination, I told you, whether they are well developed, we stage them according to Tanner, they are well developed or not, and if they are not, then we look for hormonal causes of subfertility. And then we do physical examination of abdomen and local, and look for any scars of the abdomen for previous surgery, and pelvic examination for vulva, vagina, uterus. Bimanual examination will give you any local cause or not. And similarly, as we have done in the female, general physical examination, abdominal examination, local, same way we examine male, general examination, uh, whether his secondary sexual characters are like men, are not developed at all, or he is too tall, uh, that is Klinefelter syndrome, or too short, uh, which could be due to thyroid dysfunction. And we examine the abdomen particularly for any repair of previously inguinal hernia, and local examination of the testes, their size, any presence of varicocele, hydrocele, local abnormality. Once we are finished with examination of both, remember I have said both. If you are reluctant to examine male, then ask your male colleague to examine the husband and do proper evaluation of both. Once we have done physical evaluation, then we come to investigation. The routine investigation like CBC, urine, and transvaginal sonography these days is routinely carried out for the status of ovaries and uterus. Once we have done these, then next we come to the, I told you that in 40% patients, the tubes are blocked, and another 40% ovulation doesn't take place. So if we suspect tubes may be blocked, to find out the patency of the tubes, we do hysterosalpingography. And it is a simple test carried out in radiology department. But I warn you, it is a very painful test. The patient who had hysterosalpingography done once, you ask her to have it done again, she will refuse. She will refuse. So uh, be careful in advising hysterosalpingography, and if at all you're going to do this, send her to good radiology department where aseptic measures are taken. No, because the radiology department is not like operation theater. So generally asepsis is not complete, but you have to make sure that they, and you can see these two x-rays, they show you image of the tubes and uterus. It means in this patient, the tubes are patent. Then the second alternative test is laparoscopy. Diagnostic laparoscopy is a very useful tool. I would say in my practice, I prefer laparoscopy over hysterosalpingography because it's more comprehensive. It gives you visually the information about the uterus, health of the tubes, ovaries, or any other adhesions or abnormality. Sometimes endometriosis is present, which it doesn't show in hysterosalpingography, but that could be diagnosed only by a laparoscopy. Although it is invasive procedure, it is expensive procedure, but it is gives you more complete or comprehensive information about the pelvic genitalia than hysterosalpingography. When we come to hormone assays, as I told you, that pituitary hormones, FSH, LH, prolactin, and then ovarian hormones, estrogens, and progesterone, they all give you information about ovulation status. And if you suspect that the patient may have PCO, then the SHBG, DHEA, and DHEAS are specially advised in those patients. who suffer from these. But hormone assays will generally give you information about ovulation. Very rarely, these are more advanced. If you fail to find a cause up till now, then maybe histoscopy, that is looking into the uterine cavity, finding any adhesions, polypi, may be the need of the patient. And those patients who give either history or repeated miscarriage or pregnancy loss, or you suspect ovulation doesn't take place, karyotyping may be of help, but it is only a diagnostic tool. It is academically it is important to find out karyotype, but therapeutically patient gets no relief or treatment after karyotyping, and it is expensive treatment. So be careful in prescribing karyotyping to all your patients. Similarly, male investigations, same routine CBC, urine analysis. These days in Pakistan, hepatitis is common, so B and C. Well, if the husband works in Dubai, maybe HIV serology can be advised as well. But the most important is semen analysis. For that, remember, the abstinence required is only 2 or 3 days. Generally, they are advised 7 days, 10 days, and no. The fresh semen specimen is better, gives you more information. And similarly, the next slide will show you WHO reference values. Remember those, because when I was undergraduate, the reference values were totally different, but gradually WHO has reduced the requirements, and now the latest instructions are where WHO, according to WHO, very low count, very low motility and morphology. They can also be useful for fertility. So old description you should forget. I'll show you the anime. And generally, if one specimen is poor, report, don't pronounce any judgment on that. Repeat the test, because it could be abnormal circumstances. Husband has was uncomfortable giving the specimen, or brought from home and long time waiting. So that if the report is poor, don't just announce the oligospermia, isospermia. Ask them to repeat the test as well. If you look at this, these are the parameters which are latest. Remember this. These are the values which are recommended by WHO now. Serum volume, semen volume only 1.5 milliliter. Then serum count uh, up to 39 million or even lower. In next slide we'll see. And motility 40%, and morphology at the bottom 4% only. 4% only morphology. This is comparative value. In 1980, if the extreme left column shows you what were the generally the requirements for semen analysis. Count even up to 200 million, and uh, total motility 60%, and similar. But on the extreme right, the recommendations of WHO in 2010, you can see that the sperm count is less than 39 million is okay, and motility is 32% fine, and morphology even 4% is accepted. The importance is they have laid down more on presence of pus cells or infection in the semen. Previously, they have reduced the count to even 1. If there is oligospermia or isospermia, the husband needs advanced investigation like his hormone assess. As I said earlier, the cause could be in the production of gonadotropins from the pituitary, and variant hormones, and If there's azoospermia and the uh, count or hormone is normal, then we suspect the cause could be in the testes. This could be confirmed by FNA of the testes. They take it with a needle biopsy and finding out presence of spermatozoa or not. And that will tell you whether the cause of azoospermia is in the testes, or if spermatozoa seen, it means the cause is in the cyst, vas deferens or obstruction. It will be called obstructive azoospermia. Those patients can be helped by IUI or IVF. And of course, if the testes are not producing sperms, academically, you can do karyotyping to find out the cause, whether it is genetic or not. All these parameters which I've told you, they are recommended by Royal College of Gynecologists, American Society of Medicine, and ASHRAE, European Society. So these are the latest recommendations from these three, European, American, and British. So if I summarize, a couple comes to you, then we take history of both partners, then we do a physical examination of both partners, and when necessary, do general investigations, semen analysis, and get hormone assays for ovulation and tubal patriarchy test either by HSG or laparoscopy. Remember this slide. This is again summary in this form, that history, physical examination, and investigation. If a patient comes to, this is the minimum you will do in history, in physical examination, and the investigation which are required. So I finish here, but I must tell you again that subfertile or infertile patients, they are under a lot of emotional stress. There's social pressure on them from the in-laws, from the relatives, from friends, and you have to be very kind. You have to show empathy and give them time, listen to their problems other than infertility or subfertility, and the, be sure that you've taken the history and physical examination and investigated them according to the guidelines given. Then you will find that nearly 80% of the patients who suffer from infertility or subfertility, they can be helped with modern treatment. I'm not talking about the treatment today, but my assignment was to give you only the workup of the patient. This workup means these three things you must do. Thank you very much. I hope you have enjoyed this talk. Please give feedback and make suggestions. How could we do it better? Because your feedback will help me a lot. I, I last time I gave undergraduates a lecture was in '98, so long time gone. Maybe your needs, your demands are different to those undergraduates. So please give me feedback. It will be a great help. Thank you very much. Wish you good luck. I have given you about 10 MCQs. You can keep them in your notebook, because if you keep revising them repeatedly, it will be a help because the modern examination is SCQs and MCQs. So if you repeat them again and again, it will be a help. Thank you.